You're listening to Economics Detective Radio. Returning to the podcast today is Vincent Geloso of Texas Tech University. Vincent, thanks for coming back on Economics Detective Radio.
It's a pleasure to be here.
So Vincent has been working a lot lately on Cuban healthcare. He's written first a series of blog posts, and now I believe you're working on a paper just discussing how well Cuba has done in terms of health outcomes compared to other countries, and particularly the United States. So, Vincent, how did you get on this topic? What drew you to Cuban healthcare in particular?
It's largely an accident, but an accident of fortune in the sense that for years I've been working on institutions, analyzing institutions, and my expertise is in the field of economic history, but I don't do economic history in an end of itself. It's interesting as an end, but it's also because I'm deeply interested in measuring living standards and how they changed. And the more you're playing in that field of how living standards change, the more you're forced to play with the role that institutions may have. And it's always fun to do this kind of research, but it's also kind of fun that sometimes an unexpected topic comes along where unexpectedly the skills you've developed in one field are actually quite useful in this one. And the case of Cuba, in order to assess the health outcome of the Cuban population under Castro, is actually very well suited to what I've been working on for what is now many years.
Yeah. So Cuba has sort of in political debates, the left will often point to Cuba. And I don't think it's because they want to apologize for, kind of dictatorial communist regime. I think they just want to say that even Cuba, even though it's poor, even though it's dictatorial, the fact that they have more centralized healthcare, if they could be as good or better than the United States, then that would be strong evidence for more centralization of healthcare in the United States and other places as well. And of course, you have in the public sphere, you have people like Michael Moore going to Cuba and making a documentary about how great their hospital system is. Do you want to comment on the sort of on the public nature of this debate?
So removing Michael Moore as an outlier in this debate, because it's easy to lampoon someone who's a pundit. Mm-hmm. I want to take like those who have the most respectable way of approaching this topic, and they kind of do it exactly the way you just said it. If Cuba's able to have, in spite of all the human rights abuses, able to provide healthcare to the population, isn't that something that we should at least be inspired? Another version is, can we try to sort out the wheat from the chaff and remove the abuses of human rights and systems like that to provide healthcare to Americans or in other countries? Like, what's the benefit from this one? And it's a respectable opinion. It means that you're trying to see if you can have the benefits of certain policies without all the costs. And in this case, the cost that people have most to mind is the human rights cost, the political abuse, the political repression of individual liberty. But my point in this one is coming to the debate and saying, yes, but you're considering these things as exogenous factors, while in fact they're interlinked and they're quite endogenous to one another, in the sense that violence and repression is probably one of the key ingredients for the reason that Cuba actually manages to achieve very high levels that are undeniable. There's some extent of traffic and manipulation of the data, but it's impossible to deny that Cuba, since the arrival of the Castros in 1959 with the revolution, have had a substantial increase in life expectancy at birth, a substantial decrease in infant mortality, and even if all the mistakes that have to be computed inside the data regarding life expectancy, regarding certain manipulation of the infant mortality rate, it's undeniable that given its really, really low income, Cuba is one of the poorest countries in the world. Despite that income, it achieves levels of biological living standard that are incredibly high. My point is saying, well, this high level of biological living standards is in large part either the direct or indirect product of the political means used by the Castro regime.
Interesting. So let's talk about the outcomes themselves. You have a graph in one of your posts just showing the male life expectancy at birth in various Latin American and Caribbean countries. And Cuba's up there at the top, along with Costa Rica, with where men live to over 75, or the life expectancy of a man at birth is over 75. And when you compare that to somewhere like Haiti or Guyana or Bolivia down at the bottom, Haiti is below 60, and Guyana and Bolivia are below 65.
Yes. So the figure you're referring to is basically my attempt, because I think when we're doing scientific debates like that, we have to evaluate it against the best case scenario presented by the other side, by people I tend to disagree with, so as not to kind of strawman their position. So basically, even when you compare Cuba with other Latin American countries that have more or less similar incomes or similar situations, Cuba does incredibly well. In fact, one of the countries that has an income relatively close to that of Cuba is Haiti, and Haiti has a life expectancy that is close to 20 years behind Cuba. So the average man at birth will tend to live in Haiti 20 years less, than the average man being born in Cuba. And it's impressive because inside, and this is impressive even after you do corrections, because when I got involved into this, I was very skeptical of the way the data is produced in Cuba. First and foremost, if you do some demography, the type of reporting that comes with it is very opaque, asking, for example, the WHO, the World Health Organization, to provide data at a certain level of granularity is very hard. And not only that, but they're getting the data directly from the government. So I'm skeptical for the fact that the Cuban government itself has a strong incentive to traffic the data, in the sense that it's part of their foreign policy options. They actually, in terms of foreign policy, they promote the fact that they have good health care, and they have an incentive to lie about this. And the second reason is the Ministry of Health in Cuba imposes infant mortality targets. And if physicians don't respect them, they're punished. They receive penalties for that, which, as an economist, I look at that and I'm saying, okay, so I'm seeing that they'll probably have an incentive to lie about the statistics. So I'm not able to take the statistics at face value at first. So I started looking at some of the literature, and there is evidence, for example, of births between deaths of infants between births and the 7th day of life are being recategorized as late fetal deaths. So deaths between the 22nd week of pregnancy and birth, which because these late fetal deaths are outside the infant mortality statistics, there actually are artificially deflating statistics. But the problem is, since neonatal death, the one that happened after birth, and late fetal death, the ones that happened before birth, generally share the same causal factors, you should not expect a wide discrepancy between them across countries. And once we compare other countries that collect these types of data, we find great evidence that Cuba distorts the statistics dramatically. But even once you correct for that, because now I've just explained this, once you correct for this, it doesn't explain much away. It still leaves Cuba at the very, very top of these countries. Even when, if we say, because Cuba also has a high rate of abortion, which could be induced in large part by the incentives. And there's a discussion by an anthropologist called Caitlin Hirschfield, who actually went on the ground and did an ethnographic study of the Cuban healthcare system. And she has a discussion where she asks a physician what happens if an ultrasound shows some fetal abnormalities. And the physician responds, the woman would have an abortion. And the Hirschfield responds, why? And the response from the physician is, otherwise it might raise the infant mortality rate. But even if we consider this as a problem and we say, listen, let's say 5% of abortions are, let's say, pressured abortions or even coerced abortion, it doesn't explain away the massive advantage that Cuba has. Like, even with these very dramatic manipulation of data, because you can hardly think of more extreme manipulation of data. You can't knock off more than 2 or 3 years to Cuba's life expectancy for males. So it's pretty undeniable that Cuba is actually has very high level of life expectancy, high levels of biological living standards, even when we control for the possible manipulation of it. And even in terms of level, just look at the trends where we went, even though Cuba was one of the countries with one of the lowest rate of infant mortality back when the revolution started, you can't deny that it fell dramatically from close to a little above 30 deaths per upper 1,000 in terms of infant mortality. It's fallen now to slightly below 4, according to the official statistics. Even if you accept the manipulation, it's at 11 per 1,000. So it's still a fall of, at the very worst case, 2/3 of the initial level. It's dramatic in terms of improvements in living standards, in terms of biological living standards. So you can't deny this away like many have tried in the past. It's undeniable that biological living standards in Cuba have gone up. My point is that the political repression is part of that mechanism. It explains very well why you would have this improvements in biological living standards.
Interesting. So a lot of what you've talked about, we'll get to the fact that even adjusting for all these things, Cuba does very well in a little bit. But a lot of what you're talking about, it relates to Goodhart's law. It's the idea that when a metric becomes a target, it ceases to be a good metric. So if doctors were just doing the best they could and their incentives were, say just being paid by patients, let's say, and you looked at infant mortality, then that would be a pretty good measure of, how well are we doing with our care for infants and the health of pregnant women and things like that. But when the government comes along and says, you need to get this infant mortality statistic down, you can have this situation where people maybe try to either, the sort of the horrible outcome of forcing women or encouraging women who are likely to have, children who have a high chance of dying as infants, forcing them to have an abortion, that does reduce the statistic, but it doesn't necessarily improve health or outcomes in a way that we would find satisfying. So just by creating this incentive around this statistic, which is an imperfect measure of what we really care about, we've created that Cuba has created problems, but not problems that they can measure by this particular metric. And of course, that would also affect your life expectancy statistic, because infant mortality, since if you only live for 5 days, you're right at the very bottom of your life expectancy. That draws down the average a lot.
Yeah. So when you recompute life tables, people dying at 40, 45 won't affect much life expectancy at birth. It's someone who dies very young that will have a very large impact. So that's why I concentrated my attention to infant mortality and abortions because I'm not trying to say anything like moral about abortion here. I'm just trying I have to give a disclaimer each time. The point is, are people coerced to make choices, or is there some form of manipulation either in behavior or in reporting that happens? And it's pretty clear that even when you control for that, it doesn't seem to be an issue. But your point is very well taken regarding how much when you take a certain indicator as the measure of success itself, you're kind of whitewashing away what matters. Statistics have very little meaning if they're not put inside their institutional context. I always when I give my macroeconomics class, when I used to be at HEC Montréal, before I went to Texas Tech, I would say, listen, capital is a stock, income is a flow. Technically, you could take a lot of your stock and just bring it inside your income, and then your income would boost. And this is what happened in Germany between the interwar period, especially during the Nazi time, which is why people have the impression that it was very fast growth. But all that was happening when you put the historical context in is that people were being dispossessed, their capital, their stock, became income for other people. So you could see income increasing, but it was capital consumption. So by putting it inside the framework, if I just said the statistics, incomes were increasing in Germany in the interwar period, people would say, okay, well, was it a success? I would say, well, put it inside the context of what it was. It was done in that manner. The institutions were geared towards expropriating certain people and converting their capital stock into incomes for others. Would you consider that like a worthy outcome? As soon as you add context to statistics, they take a much deeper meaning. And not only do they take a deeper meaning, they allowed for deep analysis to the causes and roots of what matters inside a question, regardless of what that question is. You really need to put it in context. And that's why I'm trying to bring forward, like in terms of Cuba's living standards, is the fact that there's this incentive for the government because this is really important. They views healthcare as their main call post, which is, look how great we are as a country. We do this, we do that in terms of healthcare. Look at how much we care. And it's been used as not only in terms of political exposure, but it's at the center of a lot of policies. If you look at how much Cuba allocates to the healthcare, Cubans allocate roughly 11% of the GDP to healthcare. This is a relatively poor country. Very few countries inside the range of income for Cuba actually allocate as much to healthcare as Cuba does. So it's a very, very important to bring back the institutions inside our analysis of Cuba's healthcare outcomes.
Yeah. So let's get on to why Cuba does so well. You have some things you've written here. You've claimed that health outcomes result from coercive policies and that health outcomes are accidents of non-health related policies. What kind of policies, Cuban policies, are you talking about there?
Okay, so there's two sets. So there's the accidental, which we could call indirect, and the ones that are out of design of the government, which are direct. But it's important to talk about what's the policy setting of Cuba. So first of all, Cuba is a dictatorship. Dictatorships are very good at maximizing univariable problems, which is, let's take a load of resources, I'm sorry for swearing, take a huge amount of resources and then allocate it to one sector. They're very good at that. And that's what they're doing. They're very good at imposing a gigantic amount of resources towards this plan.
Right, like the Soviet space program, right?
Exactly. So the Soviets could spend so much on Olympics and on the space program because it was part of the regime's ability. It could do this relatively easily because it required using force to reallocate resources, while people might not have been that willing normally to provide resources to space program or the Olympics in themselves. That's the first thing. The second thing is, inside the policies, there's a set of incentives that are very, very strong. First of all, physicians are members of the army in Cuba. So doctors are considered as part of the front line of the regime's survival. They have to report on the local population to the government. They're kind of the first watchmen to protect the government and themselves. So they're part of the apparatus of maintaining power. And not only that, but not only are they working in that manner, but they have a lot of coercive tools that they can use. And they operate under incentives, the penalties, if they don't meet targets. So consider all this brew of factors together as the constraint that people operate within and what's their incentives. In that situation, doctors have a lot of incentives to use some methods that maybe Western countries would be less comfortable with. So for one example is privacy for patient is absolutely non-existent. They will frequently report on political dissents, or so patients don't feel comfortable with doctors. This is why there's a very large black market for healthcare, which means that the 11% figure I mentioned earlier is probably an underestimation of how big is the healthcare sector in Cuba. The second thing is patients are also very reluctant, or often so. Hirschfeld, the anthropologist that I mentioned, found that in many instances, abortions, very early term abortions, were performed regardless of the consent of the mother. Forced sterilizations are not unheard of. When, for example, physicians are worried that a mother might have behaviors that would be risky to the centrally established targets, they will prescribe the internment against the mother's will of said mother inside what is called a casa de maternidad, so they can regulate her behavior. All of these are extreme measures that can indeed, down the line, lead to improvements in healthcare. If you coerce people in doing certain things, people might actually have improvements in their healthcare. But you can't disentangle here the tools that are being used from the outcomes. The tools are the cause of the outcomes in this case. And what we would consider unethical inside Western countries is being used as a manner to generate the outcomes which are mentioned. So you cannot disconnect them. That's the direct part of the equation that I've been saying, that there's a direct relation from the coercive measure of the government that is able to generate the improvements for the Cuban population. So you can't disentangle them. So when people say, oh, can we just import what's good from Cuba? I say, not really, because what's good is basically the outcome of what we would consider terrible here. I assume that some people don't want this policy. I'm not trying to say like anything in terms of, like, I'm trying to do a positive analysis here. This would be very hard to import in terms of people's normative preferences. A lot of people here in Western countries would be reluctant to take the outcome if it has to come with the tools themselves.
Right. We're having that debate now with vaccines, parents not vaccinating their kids, and it damages our ability to have herd immunity, and diseases like polio are now on the rise in some of these communities where a lot of parents don't believe in vaccines. And it's really hard for us. We'd like to force everyone to get vaccines, but it goes against all our institutions and our culture to force people to do things, especially something involving our bodies, right? It's one thing to force someone to pay taxes, but to force someone to put something, to get a shot or for their child to, is it's not politically feasible, and it's not something that a lot of people are comfortable with.
So I like what you're getting, because it allows us to kind of segue into the next point, because the direct ones are easy to discuss. The indirect ways in which Cuban healthcare is improved, Cuban health outcomes are improved, it requires kind of a discussion of the role of institution. And this is why economic history brought me to that field. Coercion does work in terms of improving public health. We've seen it with vaccines. Vaccines depend on the ability to avoid free riders who may represent a risk to the community. A vaccine is only efficient if there is a certain amount of people who are vaccinated that is a sufficiently critical mass, and generally, like, we're talking about a very, very large percentage of people that need to be vaccinated. And that kind of requires some extent of coercion. The problem is, I don't like to see it in terms of, and this is where the economic history comes in. There's a great book by Werner Trouskin, which is The Pox of Liberty, which is basically the political economy of public health in the 19th and early 20th century. And imagine it this way. The institutions that are prone to fighting smallpox or diseases that require vaccination require the use of a strong state, which is able to finance, deploy, and use coercive methods to mandate vaccination. The kinds of institutions that are good at doing that are also institutions that are not big fans of respecting property rights. So it's kind of an institutional trade-off. You either get, and property rights matter for economic growth, if you get the institutions that are good at reducing that, you might get institutions that are bad at reducing, at improving living standards in other fields of dimension, because there will always be trade-offs. The expressions that economists use, that trade-offs are a bitch, well, it really means it. Trade-offs are incredibly annoying. There's something we would like not to have in this world, but they will always exist. We will always have to have trade-offs in one way or another, because as soon as we make a choice, there is something we've sacrificed. So that's the example of this. And Trouskin, the man I mentioned, who's a professor at the University of Pennsylvania or Pittsburgh, one of these, Trouskin makes the point that there's palliative effect from economic growth. And since economic growth is encouraged by institutions that are restrained in their attempts to intervene inside markets, inside the respect of property rights, the trade-off you have in terms of health is you might be able to combat certain maladies and certain diseases through coercion, but the diseases that are maybe linked with poverty. So we're talking diseases of poverty like tuberculosis, nephritis, diseases that are that are not necessarily contagious as much as they are poverty diseases that come from poor diets, factors like that. This trade-off exists, and if you develop a set of institutions that fights infectious diseases or other factors like that, the ones that use extreme coercion, and it comes at a trade-off of lower growth, you might be less able, not necessarily unable, but less able to fight these other diseases. And that's where it's interesting, because Trojan was comparing countries like Prussia, Austria, the United States in the late 19th and early 20th century. He wasn't using extreme cases of coercion like Cuba, but Cuba is such an extreme that there might be some form of non-linearity, because think of it this way. You are so good at allocating tons and tons of resources and tons of coercive methods incite people to act in a certain way that it comes with a set of other things that make people so much poorer that it might actually have an impact, a positive impact on healthcare. And one of these examples, when I say indirectly, well, if let's say the government imposes strong macroeconomic controls over price controls, it means that some goods will go into scarcity. Let's say one of those goods is salt and people consume fewer salt, but because of the restrictions from another set of sector, the institutions that use that impose the price controls also are the ones that impose the coercive methods to improve healthcare. But because they're also imposing price controls on salt, which leads to scarcity of salt inside the market, people are not eating salt, which might be detrimental to their health. If, let's say, they also do something like restricting imports of cars, or the government is nationalizing automobile production so that it looks like the Lada market in late Soviet Russia, well, it's hard to have vehicles. So people, rather than die, they will not die from car accidents. All of these will, in a paradox, lead to lower mortality, not because it's the country's much richer or much something else. It's that the outcome of the policies leads to deteriorations in other factors, and it's only there that it's a byproduct, that there's some improvements in healthcare. I know it's many steps removed, but it's incredibly important. When I say like the examples of cars, the cars example is incredible. Cuba has had literally no increase in car ownership because of the strong restriction the government poses on car ownerships and car parts and car imports. And countries which have had important increases in car ownership, like Brazil, it's reported that car fatalities lowered the life expectancy of males at birth by 0.8 years. So it's a factor like that. So it's not even that, it's the accidental product of one of the features of the institutional apparatus of Cuba. So when we're saying let's praise Cuban health outcome, what we're doing is praising the use of coercive measures in non-health related field, which have health byproducts. In this case, people not dying on the roads from car accident means higher life expectancy.
Yeah, well, we can, there are some coercive things that we could do right now to improve life expectancy in places like Canada and the United States. You know, you could ban motorcycles and base jumping, and then you could require everyone to get vaccinated. But we have done some, minor forms of coercion, like forcing everyone on a motorcycle to wear a helmet, which is a pretty, that seems to me a fairly reasonable thing to make people do. It's not like forcing them to have an abortion or something more severe. But yeah, you can take it to an extreme. You can, if you don't care about their autonomy at all, you could go way off, into the the extreme case of Cuba and force people to be healthy. And it's a trade-off. Most people probably would not make that trade-off voluntarily. Nobody's moving to Cuba for the great health outcomes. But, you focus on this one statistic, and it makes Cuba look pretty good.
Yeah, and just see it this way. If the Canadian government decided to prevent anyone from driving a car, and let's say they have this magical device inside the car that's able to make sure that the law is obeyed at 100%, okay? And the law says you cannot drive a car unless you have this type of security belt, this type and that, and this, a series of factors that are so stringent that there is basically no one can drive a car. You would have no car accident, no car fatalities. So probably thousands thousands of lives saved in that one variable ways of looking at things. But the trade-off is we're much less mobile. We have much less access to other opportunities. There's a dramatic cost that comes with that. So we would think of this as an extreme way to improve healthcare, which is what Cuba has done. They've just done it in a way that just restricts the supply of cars so much that so few people drive that there actually are dying less from driving cars. But it also means that it's harder for them to look around for jobs, harder for them to look around for food items. They're limited geographically. It means that you probably lose much more resources in trying to coordinate things because you've lost mobility. Nobody would make that trade-off I'm not saying nobody, but if we were to offer this to people as an actual choice, one more year of life for not having a car ever, which one do you pick? So I'm pretty sure some people, it's a grim choice to face, but some people would actually make the choice of all the benefits of the car if they're highlighted relative to the benefit of 1 year of life. And this is why I'm not trying to say like anything in terms of normative choices. What I'm trying to say is that this is the cost of these institutional arrangements. The institutions that are good at using coercion in healthcare are also good at using coercions in other fields of economic and social life, so that it leads to accidental outcomes because it depreciates living standards, but it depreciates them so much that it actually has some benefits, accidental benefits on healthcare through cars, through less consumption, because the other example is through food. The price controls in Cuba mean that there's food rationing. It means that so few people get to be obese, so few people get to eat salt, so few people get to smoke cigarettes. All behaviors that people may engage in that may be detrimental to their health, but they still do it. They would still do it normally, but they're not the outcome of healthcare system. They're the outcome of non-related repressive policies and economic activity. So you can't actually disentangle the institutions, which is what people want to do when they talk about Cuba and try to assess the Castro regime, is disentangle the institution from the outcome and just try to get the outcome. What I'm trying to say here is, no, the institutions are a very strong key ingredient to the outcome, and you can't disentangle them. They're so interweaved, so strongly interweaved that they can't be disentangled.
I'm thinking maybe I would take that car deal if we could rezone every city to be high density, mixed use, and walkable. But you know, that's I don't know. I'm just sort of flashing back to if this is the first time you've listened to this show or you haven't listened for long. We've done a lot of episodes on urban economics and zoning and walkable cities has come up, so I'm just sort of flashing back to that. But overall, yes, it cars do probably overall make our lives better, aside from any terrible ideas from urban planners that forces us into them. But let's talk about where Cuba was in terms of healthcare outcomes before the rise of the Castro regime, because I mean, you've talked about different adjustments for the bad statistics in Cuba, but there's also an adjustment you have to make for how were they doing before compared to other Latin American countries.
Okay, so this is really one of the sad stories of Latin America. Cuba, and there is a lot of debate on the amplitude of this. Some people point to very high living standards in Cuba. One of them actually points to living standard in Cuba before the 1870s to be above the United States. I'm skeptical of that number, but even the lowest conservative number points to Cuba to be a relatively rich country, especially relative to Latin America. By 1960, we're talking as one of the countries with one of the lowest rates of infant mortality, one of the highest rates of life expectancy, one of the highest levels of population schooling, one of the relatively highest levels of income. So we're talking at the beginning of this as a relatively rich country. A relatively well-off country. I would not trade, I wouldn't trade Canada today for Cuba back then, but relative to other people, I would prefer, for example, 1960s Argentina to 1960 Cuba. Or something along those lines. What's important is, and this is where I think we have to care about the philosophy behind development, is that, and I know you've had this conversation with Kevin Greer regarding synthetic control. There's one working paper out there that does a synthetic control of what Cuba would have looked like absent Fidel Castro, and it would have had substantially faster growth from the 1960s to the end of the Soviet Union, because they were propped up by Soviet subsidies. They would have had considerable economic growth until the 1990s, and it would still be, it wouldn't be a very rich country. It would be poorer than the United States, but it would be 3 to 4 times, if the trends are extrapolated, 3 to 4 times richer than it is right now, which would put it as a relatively well-off country given world average standards. The sad part is, and when you put this in perspective, this is where it's important to bring the philosophy of development. I'm a big fan of Amartya Sen in many regards, because the core point, Amartya Sen, the Nobel, I think it was a 1998 Nobel in economics, Sten's point was incredibly simple and yet very deep, is that development is a question of expanding the choices that are available and within our reach. It's not only just a question of stacking up certain things. We would be very ill at ease to call development the act of putting a gun to every people's head. And this is where I become more normative than I am positive here. We would be very comfortable to put a gun to every people's head and say, do not consume this. It might be detrimental to your health. Since in indicators of development, healthcare has life expectancy as a high role, it would boost up human development as measured through stuff like the Human Development Index. Putting a gun to someone's head would improve this. But a lot of people would be ill at ease at calling this development, because inside the concept of human development lies the other concept, and it's interlinked, of human agency. It's the fact that our living standards should improve. Development happens when, in spite of all our failings as human beings, that we do stupid things many times and very often, that we're still able to improve our lot. And what I did in the paper is, okay, let's look in terms of improvements. Countries that did not pick the same institutions as Cubans, and just by Latin American standards, these countries include Costa Rica, Chile, El Salvador, and Panama. They're what you could call the high economic freedom countries. They're the ones that have had relatively free institutions. I'm not saying they were great institutions. I'm saying they were better institutions. And in these countries, what you find is that you've seen similar improvements as Cuba, which is increases in life expectancy. So, for example, since 1960, their increase in life expectancy has been 36%. Cuba's been 24.2%. Their infant mortality rate has fallen roughly at the same rate as Cuba, but not only that, but life expectancy at age, so males age 60 to 64, which is once you reach this age range, how many years more are you expected to live? These countries, these 4 economic freedom countries, have longer life expectancy in old age. They have faster increases in life expectancy at old age. They have lower age standardized death rates than Cuba does. In terms of healthy life expectancy, which is life expectancy adjusted for disabilities, they rival very well with Cuba, and the improvements are faster. They have slightly on par maternal mortality rate. They have higher rates of access to clean water. This group of countries is incredibly important for the reason that they have very different institutions as Cuba. They don't use the coercive measure. On terms of levels, they seem sometimes to be comparing really well with Cuba. In many regards, they're actually improving more. And in all regards, they're improving more than Cuba does. And that's very important because these countries also have rapid economic growth. So they didn't have the trade-off that Cuba faced, which is institutions selected are coercive institutions, which may by design, through direct coercive measures, or by the accidental design, which is sometimes the accident of macroeconomic policy or import controls leading to improvements in health outcomes. These four economic freedom countries, so Chile, Costa Rica, Panama, and for El Salvador, these four countries do much better, but they've also had much faster economic growth than Cuba did. They're a relatively rich country. Chile stands out as a very rich country inside Latin America. El Salvador has been doing much better in recent years. So has Panama, and so is Costa Rica. I'm not saying that their life is great over there. It's just that on many regards, life is better than in Cuba, and it is improving faster at a better pace than Cuba. So presented like that, Cuba's health outcomes become less interesting in the sense that we realize that we could get the outcomes, we could get similar outcomes without the cost of these extreme measures and without a trade-off as strong in terms of sacrificing incomes and other aspects of what constitute a good life, because we don't want just to maximize healthcare. We want to health outcome. We want to maximize other stuff. And these other countries seems to have been because of their freer institutional environment, are better able to generate what Amartya Sen would call development, while Cuba is not that able to do that.
So what it sounds like you're saying, as sort of the broad overview, is coercion you can trade off economic outcomes for health outcomes in the short run. You could coerce people into health, and that would have an economic cost in terms of economic growth. But it could succeed. You could make them healthier. It wouldn't backfire so much that people would actually become sicker, at least in the short run. But then you extend that out 30, 40, 50 years, and you still have your one-time gains from making everyone get vaccinated, but you haven't had this growth, and with growth comes many benefits. Well, on the one hand, there are some costs, like you have more cars and therefore more people getting hit by cars, but over time the cars get safer. And if you get hit by an earthquake or natural disaster, if you're a wealthy country, a lot fewer people die. We could compare the earthquake in Haiti to the hurricane that hit Louisiana. In terms of deaths, Haiti had a lot more. And if you live in a wealthy country, if you have well-built structures, that you can have better outcomes in that kind of scenario. And just there are all sorts of ways that wealth makes you healthy, and a few ways that it makes you less healthy. And over the long term, it sounds like you can have both health and wealth, but it's over a longer time frame than just next year or something like that.
Yeah, exactly. Because and this is the analogy, the only one I could come up in the book and in the article. Well, in the article, I've sent it a few weeks ago to a journal of Human Development and Capabilities, which is basically a journal in the spirit of Amartya Sen. And the way I present it is that there's two trees. So we can make an analogy with an orchard. There's a coercive institutional tree, which, like some very rare types of crop, can yield a very, very rich harvest. But once it does, it depletes the soil significantly. And here the soil is human agency and the personal freedom to make choices that may, in the long run, have palliative effect on healthcare. Because, as I said, the Werner Troskian argument that I was mentioning earlier is that there's trade-offs in institutions, and the institutions that are able to promote economic growth, they tend to be the ones that are respectful of property rights and tend to leave some room for individuals to make choices that best reflect their preferences, are able to generate palliative effect, which compensate for the problems of the present time. And this coercive institutional tree is to be compared with a human development tree, which in every year may yield fewer fruits, but will keep yielding fruits in the future. And in that manner, it's because this human development tree, by giving humans some form of agency, is able to generate the palliative effect from development, which means increased choices, increased ability to exert agency. So this point is basically say that if you want to evaluate Cuba's health policy, you should use this broader institutional perspective. And there is no way, and it's a simple point. I've used a long way to say a simple point, which is you can't disentangle the institutions from the outcomes. They cannot be. And I posit this as a positive point, and I hope some people will find it also convincing normatively, is that most people would prefer the human development tree when it's presented as the way I've said it. And in normative term, I actually believe it's something we should strive to much more than the one-off outcome from the use of coercive measure. Now, I'm not trying to weigh in the debate of whether or not it should be imported in the United States. If there's anything to be said about universal healthcare, I don't think it weighs much in this because it's such an extreme case. That my point is we can't use Cuba for anything inside debate over healthcare in Western countries because of the institutional apparatus that comes with it.
My guest today has been Vincent Geloso. Vincent, thanks for coming back on Economics Detective Radio.
It's a pleasure. Always a pleasure, in fact.